County Board is now in work session, continuing a work session from earlier today, but changing topics to COVID-19, which of course, earlier we were on the budget, and now we are focused on vaccine distribution as we have been for so much of this year. I do want to pass it to the manager. Before we do, we just want to note that we continue to work on distribution, and the last few days our test positivity rate has been down below 5%, but we also are still seeing the effects of the blip, the big rise in the December and January time period in terms of hospitalizations and fatalities here in Arlington. So it's the mixed picture that we continue to work on as we respond to the pandemic. And over to you, Mr. Manager.
Thank you, Mr. Chairman and members of the board. I wanted to start off with, we just sent out a press release. We just got the okay from the state to announce that on Saturday we will be having a clinic at Lubber Run, where the state is providing us with 1,500 doses of the Johnson & Johnson vaccine. And so Dr. Varghese will get into details on that, but that is good news. Also, the president announced today that he thought that everybody would be able to get a first vaccine by the end of May. So, I think that I don't want to say that the end is in sight, because we really don't know what the future presents, but I think we're in a better position than we have been over the last few weeks. I did want to share with you a graphic which is our update on statistics here. And again, I want to caution people that the only thing that we are able to focus on and verify are the doses that we receive here in Arlington as part of our Public Health Division vaccine distribution update. And I assume you can see this, and you can see that the numbers show 17,135 first doses and 9,072 second doses. We received our full complement of vaccines this week, which are around 3,140. And we have actually, week over week, from February 20th through the 27th, we were able to put 7,306 additional shots into people's arms, whether first or second doses. So that's all good news. Some of the challenges we continue to face have to do with the rollout of the state registration system. Hold on, I just want to unshare my screen here. Hold on one second. Let me know if that worked. Okay.
Not yet.
No, not yet. Okay. One of the challenges we continue to face is with the state registration system and transparency. People are still having difficulty finding their name in the state registration system. There needs to be additional work done on the state with that. We also have information we wanted to announce on the Arlington Free Clinic and what's happening there and our equity efforts. What I'm going to do is I really wanted to start with something that we didn't focus a lot of time and energy on last week, but I'm going to ask Bryna Helfer and Elizabeth Hardy, if they could, to do a short summary for us on what's going on with the Complete Vaccination Committee and our efforts out in the community. I know Ms. Crystal and you, Mr. DeFerranti, were actually out in the community over the last week, and provide you some data on what's going on with that. And then when we're done with that, we'll go over back to you and then to Dr. Varghese to go through some of those other details. But I did want to turn it over to Bryna for a minute.
Sure. Hey, thanks. Happy to be here tonight. And, we're really excited about the Complete Vaccination Committee. It's about 50 trusted community leaders really rolling up their sleeves to make sure that we're providing good education about the vaccine and updating people along the way. Part of their efforts is to recruit CVC partners, and we have over 100 organizations that have joined us in helping disseminate information through their networks. We'll be doing 2 partner trainings in the coming, in the next 2 weeks, so we can give them more information. And the CVC members have really been doing outreach. They are our ears on the ground, really giving us insights, because the group represents and really is so diverse from geographically across our community. They represent different race and ethnicities and age and just all kinds of insights. And so languages. So they're really providing our boots on the ground and ears in terms of giving us feedback about what we need to think about as we are doing outreach and unique messaging. The good news is that we're getting a lot of really interest in a lot of big interest in the vaccine. There is still some hesitancy in some groups. Other groups really aren't hesitant and want to have better access. So those are some big takeaways. In the last week, as Mark alluded, we've been doing pop-up registrations to help as many people get registered as possible. And those registrations, we did almost 100 real-time registrations over 4 or 5 events. These are at AFAC, at the Food and Assistance Center. We are at Marabella, at the Shelton. We're with APA. We've put 2,000 flyers under every apartment in the APA buildings. We have been giving out COVID kits with hand sanitizer and face coverings and flyers about Vaccinate Virginia. For those people who aren't quite sure if they want to pre-register or maybe don't have the time, we're sending them home with additional information about pre-registration, how to do that, if they need additional assistance with that, who to call, and then also information about food and emergency assistance. So it's really been great. And I don't know if Elizabeth wants to add anything to that, or Katie.
Ms. Hardy, are you there?
I am here. I'm a little slow with my
No
tech
worries.
skills these days. Sorry about that. Good evening. Yeah, I want to say that the pop-ups are really amazing to be out there in the community, to be able to talk with people, to give the information, give the right information. Really had great feedback. I attended one last week at AFAC, and really talking with people and having them understand, how the vaccine will help them and how it helps our community. It's really, really great to be in the community doing that. We had a lot of great positive feedback from people. I think most people just didn't know that they could go ahead and sign up, and they'd go ahead and do it. And if someone was hesitant, we would say, as Brianna said, just put your name on the list. You still have time to think about it, but it's really important to save your spot, get on the list. So hopefully we'll be able to reach everyone that needs that special assistance and to get them signed up and pre-registered.
Great, thank you. I see Ms. Crystal is
Yeah, the only thing I would add too is just a really important role that our CVC members have been playing is being critical friends to us in the county. And so I want to thank actually Brianna, who's done a lot of work along with Elizabeth. When we say that we want them to be our eyes and ears out in the community and bring back questions, they have risen to that challenge. And so, sometimes having those folks who are on the team ask those really pointed questions that they're reading on their neighborhood listserv or they're hearing at food distribution sites is a really important role that they're playing too. So we appreciate them for that as well. And I'm looking forward to seeing everybody at AFAC distribution on Friday morning.
Oh, there you go. I will just say that the chance to be at the Career Center with Claudia on your team is just a great, we helped pre-register some individuals who really needed a little coaching, had some questions, which is of course reasonable. And it was great to do it. And there was a food distribution nearby. And so that's wonderful. I also think it's a significant resource to have both your relentless energy and leadership, Bryna, and also Ms. Hardy, your background on census tracts, because we know we want to keep focusing where there's the greatest need. So appreciate you both sharing with us. And Mr. Manager, back to you.
Okay.
Mr.
Yes,
Carantonis, sorry.
Just shortly, just to think, to align with all the thank yous. A quick question, very short one. So it seems that the pop-up registration system works, that we get a lot of people in, but there are also people who are actually volunteering and working at these pop-up locations. Is there any plan or any possibility to, because they are more exposed, to immunize them, to provide a vaccine for them as active volunteers in the community?
I will pass that back to Dr. Varghese. Thanks.
Okay, so appreciate the question. I think that we'll say, I think I know what Ruben's answer is, but regardless of the answer, wherever you are out in the community, you want to practice being masked and, you know, trying to keep distance because we do not have enough vaccine to meet all the demands on there. But, you know, I know we've been building up with eager anticipation for Ruben's discussion of all the items that I teed up for him. So over to you, Ruben.
Thank you, Mr. Manager. Thank you, Mr. DeFerranti. And I'll take Mr. Karantonis' question first. While I understand the desire behind that, there is, you know, the way the exposure risk calculation, they're not at any more risk than, say, a grocery store worker, and the question becomes, like anything else, we check with the state and they did not actually say that this sort of activity should be moved up in the prioritization, because a number of groups would actually fall into this. And I wish I could provide everyone with vaccine right now, but that is, you know, how to justify it is going to be tough, and getting people registered hopefully does not necessarily equate with that they're at greater risk. Remember, everyone has a certain risk out there. The question is, are there certain activities that put you at greater risk, first of all, of being exposed to people with actual illness and so on? And this activity has been, I think, well planned, and people are keeping the distances and limiting the time as well. So it reduces that risk. So thank you. With that, I was just going to remind people a little bit of where we are. And so I'm going to share some content with folks, and it may be a little repetitive of some things, but I think people have always wanted to know where we are in the pandemic curve. And I'm hoping you are all seeing the traditional graph that you've come. Thank you, Mr. DeFerranti. So the good news is that we have seen a steady decline since January from the peak of 702 cases that week at the first week or second week of January. So we've seen a decrease in that. Unfortunately, our level still isn't as low as it was back in the summer months. So I will not be satisfied first time until at least we get to the summer level. And obviously I'd like to get to zero. So that may not be so practical, but wanted to remind people of that. The next thing, you know, as Mr. DeFerranti did point out, should have switched to a table. Sorry for the graphic, but our percent positivity has significantly decreased from a peak of close to 12.7% in the end of December, and we're back down to around 5%, which overall is obviously significantly a significant improvement, and I'd love to see that number go down. So encouraging people to do as much as possible to do all of the layers that they have available to them, stay in their home bubble when you leave, keep 6-foot distances, and wear face coverings when you can. The manager reviewed the vaccine data, and one of the things I want to make sure people are aware of when they look at the VDH data that's presently provided, what's recorded there are any Arlingtonians that may have received a vaccine, and people need to realize, just as we are vaccinating essential employees in the first groups that work here, not everyone who works or lives here. And so our residents are getting vaccinated in other places as well where they work. So that's why the numbers are sometimes hard to reconcile. And we've been focusing on what we're actually currently delivering. And the good news is that the federal government the FDA did approve the emergency use authorization for the Johnson & Johnson single-dose vaccine, and it is felt to be safe and effective. And one of the advantages would be that it is a single dose, and so there's no need to worry about scheduling that second dose as we have with Moderna or Pfizer. So there are pros and cons to either in people's lives, and hopefully when a person gets access, you'll agree to just go ahead and get the vaccine. As Dr. Fauci said, the one that's available to you is the most effective vaccine you can get. The final thing that I wanted to present was, I know people have been concerned about the race and ethnicity data for vaccinations. And so what I had staff do was pull together the percent in the populations as we've listed on our county dashboard for cases, and then list the rate for the cases and then the vaccination percent for just the Arlington individuals that we have been responsible for in our clinics. And one thing I need to point out for anyone who's concerned, we know we're behind on the case entry for the unknown race and ethnicity data. We had to make a decision when cases got quite high what we would focus on, and we were shifting towards vaccination. So we will do the back entry to get the unknown entries. We actually have the data in another database, but we have to actually get that transferred, and it's a manual process, get that entered into another database. But what this hopefully shows is that we do see all race and ethnic groups represented, but it will be, as soon as the case data for the unknowns gets put in, my suspicion is, like previously, we will see that the case rate is disproportionately, once again, among the Hispanic population. And so the level of vaccination, while it looks good here, and I'm encouraged that there is among the population that we have seen 26% receive vaccinations, we'd like to see that be even higher one day, because obviously the Hispanic population has disproportionately been exposed and have higher case rates than the rest of the Arlington population. And one last thing that I don't have a graphic for, but I know people are interested in, and I'm happy to repeat the data. Among the 75 plus group that we had pre-registered, we have invited 100% of those individuals to make appointments. For the 65 to 74-year-old age group, we have invited at this point 87% of the individuals, and we expect to be done with those invitations either at the end of this week or by the end of next week. And we have also started inviting 16 to 64-year-olds with underlying medical conditions. And at present, we have invited close to 18% of those who are pre-registered, and that's after deduplicating the email addresses. So just wanted to provide all of that, and I am going to stop sharing my screen, and I'm turning it back to, I believe, Mr. DeFranti.
Thank you very much, Dr. Varghese. That's a lot of information quickly and helpfully presented. Appreciate it. Mr. Dorse, oh, sorry. I think Mr. Schwartz had a point.
Yeah,
first.
I just, sort of by way of doing all the information out there at once, I wanted to give Dr. Miller a chance to give us a quick update on how we were doing at 7999, because I know that I will just say the people there are just, being deluged with calls, and also a lot of them, going through the emotional ringer, but let him to sort of give us a quick summary on that.
Dr. Miller.
Sure. Thank you very much, Mr. Manager and Mr. Chair. I'm happy to present to you the updated call statistics you should see on your screen. As you can see, consistently staying around 1,000 per day average, with significant spikes on the ends of the week, because, as we know, generally a lot of news comes out on Friday, or people have questions over the weekend as they've had a chance to digest, read through, and see what else is out there. We'll say that the majority of our calls continue to be about vaccination and pre-registration. Starting this week, our pre-registration calls are going to the state pre-registration call center, so that those agents, we've spoken with them, looked at what their staffing is. We feel confident that they have the necessary people power to support assisting residents through the pre-registration process. So up until this week, we had been assisting folks with that process, with the Vaccinate Virginia website, with filling out the information and manually entering it on their behalf and helping them navigate it. We believe the state is getting to a point where they have the people power to do that. And so we've moved those pre-registration calls over to them. So we still have a phone tree, which allows residents to pick both in Spanish and English the type of support that they need, so we get them to the right place and get them the right information. Those pre-registration ones specifically will be going to the state. We think that that's going to help cut down on the call load fairly significantly. And that's all I've got for you now.
Great, thank you, Dr. Miller. So we'll start with Mr. Dorsey, and go ahead, and we'll have questions.
Thanks, Mr. Chair. So, Dr. Varghese, the slide that you were last on when you concluded your presentation, can you walk us through how we are not yet through with the invitations from the 65 to 74 group, but have almost gotten a fifth of the people 18 to 64 with underlying conditions? Just why is that?
So, Mr. Dorsey, if I understand your question correctly, is it why have we not finished with the 65-year-olds before moving on to the 16 to 64? Is that the thrust of the question, or?
Right, essentially,
okay.
Yes.
Okay, so it's a great question. What the governor had essentially said was try to do the 65 and above as 50% of the vaccine, and then the remaining frontline essential workers and 18 to 64 were the other half, and trying to have a balance. And one of the things that people didn't know is that the phase 1A category kept increasing. So we were still inviting people from that. And the first three categories from 1B were also, we were still uploading and people were making appointments. So we were actually, some would say, behind on the 16 to 64. Other jurisdictions have done it, others still haven't. So we have now started to add the 16 to 64. It was a decision the governor made, and we're following through on that. But the good news is that we are close to being done with our pre-registered, the Arlington pre-registered category. And then when we have access to the state system, we will pull down the appropriate groups and start inviting them at the appropriate times.
And for all of these categories, thank you. It's still true that we are, the priority order is the order of when one submitted a registration?
Yes.
Okay. Have we ever considered something, I know this may sound radical, but instead of, doing order of when the timestamp of the registration is, by maybe thinking about people in buckets, looking at folks who registered during week X and then randomizing within that?
We have thought about that, but it was actually the direction of the state that things be done in order of receipt. The one concession, and this is where they decided with the efforts on equity, which I completely agree with, can we prioritize areas or organizations that serve those individuals? And that's why we went into the partnership with the Free Clinic to be able to have that ability. So yes, otherwise we would have considered the randomization sort of activity, but it is currently the statewide, as a general rule, it is by order of pre-registration. And
is there any way that consideration can change? I know your commitment to equity, we all share it. In many ways, given that we effectively are prioritizing people who are better connected and know about processes and procedures and can follow them, we are essentially prioritizing them for distribution of vaccine, which seems somewhat inconsistent with those efforts. I'll just leave it there for now.
I agree, and that's why we are working with a Free Clinic, and hopefully we can actually increase their capacity. And as vaccine supplies increase, we can also allocate more vaccine in that way. So I'm going to probably shoot myself in the foot, but it'll remind people, actually the individuals who have access to the Free Clinic still have access to our system. So there's actually two streams, that one of course is going to be behind the other, but that doesn't mean the reverse is not true. People will only have access if they meet the Free Clinic eligibility requirements for being underinsured or uninsured through referrals. So.
Great. Thank you, Dr. Varghese. And for the questions, we do need to, the Free Clinic is a start for sure, and we'll continue to focus on equity. Ms. Crystal.
Thanks. I've got quite a few, so I'm going to go with maybe two of the briefer ones, and then I imagine we'll do a second round. Just a very quick question for Aaron about call takers. So you were describing, sorry, Dr. Miller. So you were describing transitioning folks who have questions about the process of pre-registering back to the state number. One of the things I know that our team has gotten questions about, because we're getting questions about them at the board office, are, that recurring issue, my name is still not appearing on the state site. It's always a good opportunity for us to reassure folks that we've got their name in Arlington County. They will still get registration opportunities in the order in which they signed up. But are we transferring calls for people who have questions like that back to the state? Because I have heard a couple of examples of, because the state call takers maybe aren't as trained in what our local system looked like before, they're handling statewide, people are not getting correct information. So that sort of subset of registration questions, how are we handling those?
Yeah, so we've set up, and I will say, as I said in my previous work session with you all, the folks at the Department of Environmental Services, DES, the DPR, library staff that are doing this, DHS staff have done phenomenally. We've actually set up an entirely new call center, call system, and call queue. There is what we call Tier 1 and Tier 2 support, right? Exactly like you would have in any other call center. Those sorts of more particular sticky issues, we do have an escalation mechanism. We do have teams of folks that are able to access the data and help answer some of those more individual questions. We don't always get that as being the point of the question, and sometimes it's difficult to direct where to go because of, I will say the lack of unified direction in this at this point, right? I mean, halfway through this, the state decided, look, we've got a better way, and here's this idea for the unified call center and registration. I will sum up by saying this. All of the 41,000 individuals who pre-registered with Arlington County, we have their name, we have their contact information. We are using that list to send out our invitations, period. We are proceeding in the priority order that Dr. Verghese just described as the Virginia Department of Health has set out for him. And so, as much as I can say, when people say, look, I don't see my stuff in the state system yet, that's okay, because Arlington is still using the pre-registration data we had to schedule our appointments. We know that there will come a point when we will run out of names, but I can promise you that when that time comes, we will have access to the state data, and we're actively working every day to figure out how we get it, how we can get it in a way that's usable, because that's some of the problem right now with data migration. And yeah. Yeah,
and so just to clarify, if somebody calls the Arlington County hotline with that question, I pre-registered with Arlington, I'm not seeing my name, they'll get an Arlington person who can tell them what you just told them. They wouldn't get kicked to the state hotline for that.
Yeah, we do have the ability and are checking and verifying with folks by reading back the email address and things like that.
Great, that's reassuring. A question for Dr. Verghese. When we last spoke, this was sort of something I know you guys were working with the state and maybe we're working with the CDC on. Now that we've moved into that 16 to 64-year-old category, one of the big questions is, I have X underlying condition. Am I eligible? This has been really top of mind for me. I've had a chance to speak over the last week or so with a couple of different disability advocacy groups in Arlington. And as you can imagine, right, this is questions like, if I have autism spectrum disorder, what does that mean for me, right? I know the state has some good guidance, but it's not, there's no way to encompass all of the medical maladies that may be part of the human experience. Do you have high-level guidance for folks who are trying to decide, would you recommend they speak with their physician? Are there sources of information beyond the CDC or inclusive of the CDC and VDH that you direct them to? I mean, those who are trying to do the right thing and figure out if their condition should make them eligible, what would you recommend?
Sure. Thank you for the question, Ms. Crystal. So I wouldn't send them to new sources. I think the CDC and VDH have roughly the same guidance. The general principle is, are you more at risk, in a sense, for complications because of the medical condition you have? That's a discussion you can have with your physician as a general rule. The problem is, we're not going to be checking, okay? And I'm just going to put it out there. We are trusting, and society is built, and I learned this from Dr. Miller, one of the ways he talked about it. For us to be successful, we need people to play fairly and go, all right, here's the list. And, yes, smoking is on the list. Please don't start smoking tomorrow to be eligible. Okay, one, that's not a good idea. And I'm being facetious in one sense, but we've got to remind people that this will only work if people truly claim what their risk is. If they're not certain, speak with your medical provider. If you're not at risk for increased complications because of your underlying condition, it's okay. Just because you have a medical diagnosis doesn't necessarily mean you are at risk, at increased risk from COVID. And that's the distinction that people need to think about. So there isn't a specific list because, as you have said very clearly, there are so many more diagnoses out there that they may not have necessarily put into a bucket. But if your doctor has ever talked to you about having, a poor immune system, that would be the way to think about it. So if you're not sure, work with your medical provider to determine that if you should be someone registering for the 16 to 64. And I'm going to take one opportunity. People will hear about the vaccines. There's only one vaccine right now that people can get who are 16 or 17, and that's the Pfizer. So you'll see for this weekend's Lumber Run activity with the Johnson & Johnson, that's 18 and older because it's only been approved for 18 and older. And I know that gets tough for folks, but we're not trying to be difficult. It's just one was studied down to age 16, the other two only 18 and above, and they're conducting those studies to go lower, but we can't go, there would be bad practice to vaccinate someone under 18.
I'm sorry, I just want to make sure I'm following that. So that is true for people who are 16 to 18 with underlying conditions, or for simplicity of administering, everyone who is in the 16 to 64
Correct.
Category.
Yes. So basically anyone under 18, only Pfizer is available at this time, regardless of medical condition. Thank you for the opportunity to clarify. It's the age is related to what groups were studied by each of the vaccine makers, and Pfizer actually studied children from 16 and older, whereas Moderna and J&J or Johnson & Johnson only studied people 18 and older. They are going to do trials to do people under 18. But I wanted to make sure, because we've had some confusion. People are coming going, well, my child is, it's like, well, yeah, but we only have Moderna today. We can't give it to you. It would be inappropriate.
But if you are between the ages of 18 to 64 with an underlying condition, you may well get an invitation to the Johnson & Johnson. Okay.
Absolutely.
Thank you for clarifying.
Great. Thank you, Ms. Crystal. Just thinking about the last week or 2 weeks, supply of vaccine has been our biggest concern. And just to reiterate, 1,500 doses on Saturday is good news on the supply front, very good news. And then we all have been hearing for weeks from those 16 to 64 with underlying conditions. And we also have good news there in that we moved on Friday to batches of those individuals. A third concern has been equity, and we have good news, not perfect, but good news that we're working on the free clinic. So I want to get to, I know we'll have additional questions, and there's so many different possibilities, but also wanted just to highlight, at least from my perspective, imperfect, but good news. And we'll keep asking questions. Sorry for that interlude. Mr. Karantonis, you're next.
Thank you, Mr. Chair. Yes, this is all indeed very good news. The first thing I wanted to ask Dr. Miller, because constituents, I got a surprising call yesterday that somebody had to wait up to 1 hour or more at 7999, which really surprises me because A, nobody else that I know of, and B, really your data show that we normally respond within 5 minutes or so, right? So that's must be an outlier, some technical problem.
Yeah, so I can't speak to the individual call, but I'm looking at the data. Our average call, or excuse me, our average speed of answer, obviously when we've got 1,100, 1,200 calls, is somewhere between 10. It looks like the worst day was about 19 minutes. and I'm just looking. Average handle time about 5-6 minutes. We're spending about 5-6 minutes on the phone with some folks. These are complex questions. But yeah, there may be some times when in the queue, simply because of the number of folks that we have, there are extended wait times.
But extended, not like 1 hour or more, extended as in half an hour.
Yeah, I mean, I haven't heard of anything as an hour, but I'm happy to get with the team and look into that.
Yeah, the second thing is, the Johnson & Johnson vaccine is now available, and we get a first shipment that we can administer on Saturday, which is yes, excellent news. Dr. Varghese, does this mean that we should be thinking also to expanding the Arlington Mill, the preclinic program as well?
Good question. We are starting first with the free clinic, and they are starting their own activities this Saturday, if all goes well. But they have to ramp up their own ability to get there, and we will support that, but they have to work through their processes. So right now, the county is doing the activity, but what we are asking the free clinic to do with its partners is we are setting aside approximately 10% of the doses for equity purposes and asking the free clinic to work with its partners to identify people who would fit into the eligible same categories outside of our invitation process so that they can actually fill those slots. So we'll be turning over that scheduler to them tomorrow and asking them to schedule people with their social safety net partners to take approximately 140, 150 slots. So that's how we're trying to address that for Saturday. On the question of Johnson & Johnson, which you didn't ask, but I want to set expectations, they have told us that this week was a surprisingly good week for Johnson & Johnson across the nation. They have also said that expect the next 2 weeks that the supply will actually go down across the nation. So we do not know how much Johnson & Johnson the state will get, and then let alone will we then get it. And this was a initial thing to make sure people understood, like a blitz with Johnson & Johnson. Hopefully we'll be able to start incorporating it into our regular practice, that maybe a morning is Moderna and the evening it's Johnson & Johnson. And we are not going to advertise ahead of time what it is, because the philosophy is whatever is available is really what you should be getting. We cannot do choice at the clinic. It will actually increase the amount of time. And if the purpose is to get shots into arms, I just want to set people's expectations until there's so much more vaccine available. It is what you're offered is your choice at that point.
I perfectly understand that. I mean, Johnson & Johnson was emergency approved. It is safe and efficacious, so that's not a question. But there was a significant quantity pre-produced, so this quantity is now circulating in the United States. My question now is, so let's say somebody, for whatever reasons, has a hesitation towards one brand of vaccine. What happens with this individual? So the invitee comes to the center, figures out that she or he will be vaccinated with, say, X, and said, well, I have a hesitation about X, whether this is warranted or not, whether this is logical or otherwise justified or not. The patient says no. So what happens with the registration of this patient?
Well, that individual will not be getting vaccine that day.
And where in the queue will this person land?
They will go to the end of the queue, because we cannot actually assure, because otherwise it's already hard enough to maintain the scheduling, and people think this should be actually an easy process. If they look across the nation, this has not been an easy process. And we are actually, to reassure the people, we look to see if people are not getting, like if they've got the invitation, like they've been sharing and they're not supposed to be on it. We've canceled folks. The amount of work that we and my colleagues across the nation are doing on this is extraordinary, and we do not have the ability right now to have that choice in that same way. I apologize for that, but right now, if it's safe and effective from the FDA, we'll just have to say, I'm sorry, but this was the slot for today. The state may change that policy, and then we'll have to address it at that time. But my druthers would be to actually not do that, because imagine having to keep canceling and we go with slots unfilled. That actually defeats the larger purpose of getting to community herd immunity, which is one of the things that I'm also trying to do in this process. And I know public health professionals across the way, and you all would like us to get to that point where we don't have doses sitting on arms because of people's choices on that respect.
Thank you, Dr. Verghese. I perfectly understand. I yield, Mr. Chair.
Thanks. We'll come back. So, I mean, on Johnson, oh, go ahead, Ms. Garvey, and then we'll go to the second.
All right. Although I was going to take us off in a slightly different direction.
Well, this is a science question on Johnson & Johnson. I mean, we all
go for it, Mr. Chair. Go for it.
Thank you. We all, or you know, everybody has different sources of news. I want to understand if my impression from the news is consistent with your reading of it. That Johnson & Johnson is highly effective at preventing fatalities and severe hospitalizations. Correct? So yes. I just think we ought to say that in addition to every source of news and I wanted to, you know, make sure that my impression was correct, because one dose, and, you know, we wish we were in the place of preventing anyone from getting ill from COVID. We're in a place of trying to save people from severe hospitalizations. And we're mindful, at least from my perspective, we're mindful that we've lost over 200 people in our community. So that's the standard that at least I come to, you know, with respect to Johnson & Johnson. And, you know, I don't see any vigorous contradictions from you. So we'll go, if that's okay, we'll go to Ms. Garvey for a question.
Sure, thank you. First, I say, I feel like we kind of turned a corner with this work session. This has a little different feel. Like we've kind of got all the pieces and there's problems and we're figuring it out. It just feels like we're in a different spot. We're at the beginning of the end, maybe, which is great. I think this is for Mr. Miller, and I would like to have, if you wouldn't mind, Dr. Miller, talking a little more elaborately about what people can expect once they've signed up with the state and their turn comes up with the state. As I understand it, it's supposed to happen. The state will send us that information and we will reach out to them. So their experience will be hearing from us when it's time for them. I know there are issues with the state, but presumably they'll have that worked out. But that's what people should experience. Is that correct?
Well, so this is where I'll say it depends. So yes. And in the best case scenario, that is what would happen. But you have to remember that the state and federal government have increased supply chain to through other avenues that we don't control. So CVS, Walgreens, Safeways, for example, some of those are being scheduled directly by the CVS, the Walgreens, the Safeway, or through callbacks happening from the state call center. So we do know that some residents in our community received a phone call from the state call center to actually schedule them for an appointment at a Safeway when they had appointments available. And so what I can tell you is that it is our preference that we get that information, be able to schedule and connect you. But we know that as avenues grow and as supply chains continue to increase, that there will be other mechanisms through which individuals can schedule and will be scheduled. And we're continuing to ask the state for sort of their roadmap as to what they see the next few weeks looking like as supply increases, but don't have much in the way of the crystal ball. It's still a little foggy right now.
All right. It just means more and more it's out of our control, which is always hard. I think when we're controlling it, it's going pretty well. But all right, we will cross our fingers that this will all just work great. Thank you.
Thank you, Ms. Garvey. Yes, there's plenty of uncertainty. It's also the case that we moved through, at least to my recollection, we've moved through the registered 65 to 74 faster than we thought we would. So, Ms. Crystal, question for you.
Thank you, Mr. Chair. I know, I don't know if we're going in even rounds. Mr. Dorsey, did you want to go next since you were a lead off there? Okay. Two questions. The first, I think, a request actually. Dr. Verghese, you showed us some data, I think it was on your slide 4, about, which I think was a very helpful comparison, the percent for each racial and ethnic group in Arlington, the percent of the Arlington population that group comprises, the percent of COVID cases they comprise, and the percent of the folks vaccinated to date they comprise, which is really helpful. If I could ask for one more thing in the future, one way that the state presents the data, I'm hesitant to cite it because I know we've got a lot of challenges with the state data and validating it, but one of the ways they present the data that's been incredibly helpful to me is the percent of the population, that ethnic group or racial group's population that has been vaccinated. So for example, if you were to go on the state's website right now, search by Arlington, again, that data is problematic. We can't validate it. We're not using it for a variety of reasons, but you can see how they present it to say 5.8% of white Arlingtonians have been vaccinated. 7% of Latino identifying Arlingtonians have been vaccinated. And to the extent we can present it that way, I think it's I don't know. I find that really helpful to be able to talk about that. All of the caveats in place about the state data to just see that we actually vaccinated a greater percent of Arlington's Latino population than we had of its white population was very powerful. There are no laurels to be rested on here, but to know that at least potentially, and we'll have to see if our own data when presented that way keeps the trend up. But despite all of the challenges, a system first come, first serve that would advantage sort of better positioned or better resourced folks, starting with age populations that would be wider, to see at least in that, again, flawed state data that we were vaccinating a greater percent of Latinos, Arlingtonians than we were white Arlingtonians when this disease has so decimated our Latino community, give me a lot of hope that actually as we expand now with the free clinic, as the CVC does more of its work, as we get into younger age cohorts, that actually we can maybe buck the trend of what I know people are seeing in national news, because I'm seeing in national news of tremendous disparity in who has access. So anyway, I find those numbers helpful. I don't know if there's anything you wanted to comment on beyond probably my citing state data giving you heartburn.
No, Ms. Crystal, it's a very good question. We do want to be able to get to that point. We do have some concerns on how they're calculating some of that. So until my epidemiologists are comfortable with it, we have reason to believe that they may have actually kept the whole population of Arlington for each of the categories rather than actually removing out those under 16, for example. Those are some of the things that, if that's true, I mean, it's the same level of inflation or dilution, but it's those sorts of details. When we're aware of that, it makes us uncomfortable about how to do it, and we can do some of those calculations potentially ourselves with our own data, but I want to make sure staff have enough time to actually look through it. And I know to Mr. Dorsey's point, in some ways, while there is hope, we do need to remember that there are disparities and nothing has changed in our system. So I want to remind people that's why we're trying to do it, but there is a gap. And so how do we overcome that? And one of the things that, because of our desire for equity and the state's desire as well, as we get more vaccine, if we can actually enfranchise the free clinic or add to their resources to be able to do more, that's one of the things. But I want to make sure that they have the ability to ramp up in the right way. And then, as I said, almost having those two channels through the free clinic as ourselves. And if there's enough supply, what we'd like to do one day is make sure that it's the pharmacies and the private sector that's doing it. And then we can go with partners to smaller venues to actually just do it in that sort of way, because that would make it much more effective, even more effective for the disenfranchised communities. We don't have to be involved as much as we provide the vaccine to providers that they work with to have that happen. But while there's hope, I would like to make sure we remind people there are disparities in our system, and I'm hoping we're also willing to start tackling them systemically longer term, because this is never going to go away if we don't tackle it head on.
I really appreciate that. And one of the things that I find so compelling about the free clinic partnership was exactly what you were describing when we last met too, is that it's a way of giving people for at least maybe a few weeks around their receiving of the vaccine, a medical home, so to speak, right? And that is the long run disparity that we have to get our arms around. So sort of another channel, right, that we think, or that we have plenty of reason to believe there are disparities in who works there, is a group that's probably about to become eligible, which is grocery store workers. And one of the patterns, I don't know, my colleagues would agree, but what I find is as we're about to expand to a new group, it is the perfect time to get a million questions about the logistics of getting that group enrolled that I otherwise never would have thought of. And so some of the questions I've heard from a few different folks in the community are pretty specific to especially reaching the sort of smaller bodegas or the mid-size independent grocery stores and so forth. If there's anything you wanted to speak to at a high level, that could be helpful, but I also am cognizant that there are going to be specifics. I mean, we got one today from one group of residents concerned about a specific grocery store that they had heard had been denied. Rather than trying to use this forum to resolve the specific concerns, if folks have questions about, I'm a grocery store worker, my boss won't sign us up, or I'm the manager of a small bodega and I'm not getting the response that I want, where would you direct them? I'm wondering, maybe the hotline may not be the best place. How can we get folks answers in that category?
It's a great question, Ms. Crystal, and I'll start, and Dr. Miller may or may not want to add anything further. But so we have made outreaches to grocery stores and other groups in the 1B sort of phenomenon prior to the state system, and we have that information, and we will use that as a launching point. For employees who are concerned, they can register with the state system. They'll have their jurisdiction of residence. If they're not a Virginian, then they'll have to also give their place of work, but you can do both, and they will then provide us that information. It'll be similar in some ways. It's a little messy, but we may invite the employer group initially in 1B and then do cleanup with the others if their group is not willing to do it. We can't force anyone as an employer to provide these sorts of things for whatever reason if they've got concerns. But one of the things we've had as a general rule, we've had most employers seem very willing once we tell them what's happening with the data. We're not sharing with others. Some people are worried about their employees' status, for example. We're not asking any of that information. We're not sharing that information. Once we get the registration information, either here or at the state, that is considered protected by HIPAA. It is not releasable for other purposes. So hopefully that reassures some individuals, and I'll leave it there, but I know we've been working with our Arlington Economic Development to help with this, and this is where I'm going to turn it over to Dr. Miller.
Sure. So absolutely right. Our economic development team has been helping us to outreach to businesses. We started with a list that was given to us from the Virginia Department of Health, as well as a few of the other state agencies that had, for example, lists of licensed businesses that are those that fell in certain categories. Leveraged some of those lists that we have from our local permit database, and then began outreach. And I'll use grocery stores as a great example because I think, even though I do want to answer this one specific question that I know some folks may have had, we began outreach to eligible groups within the categories of Phase 1B, and as appropriate, ask them to go ahead and submit lists of individuals. At the time that we did that, you may remember that we did not yet have the order from the governor to have 16 to 64 moved, as I call, up the line of priority. At that time, we were asking folks for their list of individuals. We had a reasonable expectation that based upon our allocation, the rate at which we were providing vaccines and our pre-registration list, that we would be closer rather than further away to actually scheduling an appointment for those individuals. We were right in the middle of doing that with grocery stores. So some of our grocery stores have pre-registered, but we have not yet gotten the list from them simply because we had this mandate to move up the list in priority a large population of individuals who pre-registered, over 20,000 people. The result of that, we kind of said, was when we call people and ask them for the list, they get very anxious about when their appointment is because that's the next logical step. And we have had to have conversations over the past few weeks with many businesses who have already provided the list and explained to them, okay, look, the priority order has changed. the governor has directed this allocation 50% 65 and older, 50% to 16 to 64 with underlying health conditions and essential workers. And it just, in the vein of not trying to cause any more anxiety for an already anxious system, we sort of have paused asking for the names specifically. So I think that's what's happened in the specific case I think that we've got with this one grocery store. We have the pre-registration information. We're absolutely going to reach out to them and make sure that we include their individuals and upload to offer appointments. But we want to make sure that we're doing that with a reasonable estimation of when we can provide them a vaccine. Two things that I want to highlight for those businesses and employees out there. You can visit the Arlington, I pulled it up, so I'm looking at the website. You can visit the Arlington COVID website, and we'll make sure that we put the link up. But we do still have the employer registration form so that we can take the information and know that somebody is eligible within a category. So we encourage all businesses to visit that form, pre-register. And like I said, we're working with economic development and the biz launch team specifically to make sure that we're reaching folks in the community so they pre-register. Then we'll get with them and get the list specifically.
Okay, so my takeaways then is if you are the manager of a grocery, a bodega, midsize, and you've been in contact with the county before and you have questions, maybe along the lines that you just highlighted, Dr. Miller, you can call your contact at BizLaunch, or who you've been in touch with from the county before. You can register again or for the first time at the county's website, which we'll share more widely. And then if you are an employee who for some reason thinks that your employer, your store manager has not registered you, pre-registered you, and you'd like to be pre-registered, you can do that. There is an option to do that on the state system. Have I got that right?
Yes, you did a much better job than Ruben and I.
No. I think
wholeheartedly agree.
Trying to uncover the source of the confusion, right? Okay, so I think that's really helpful. I appreciate it. And then this is a perfect opportunity because Dr. Verghese, you are emphasizing again that no one is collecting identification, government identification at any point. So when you show up to get your vaccine, you do not need to provide photo ID or government ID. Is that right? Oh,
Yeah.
You're muted.
Oh.
Okay. Fortunately, I didn't say anything brilliant in that moment. So, so what we are doing is like anything else with DHS. Obviously, you can provide a government ID if that's what you'd like to do. Photo ID, we just require some proof of, if you're a resident, proof of residency. And so using things like the cell phone bill with the address or so on. We're not standing on significant ceremony, but if it's really based on residency, we do need to know that phenomenon. Otherwise, it is hard to, keep it fair for folks. But we're not asking for a government ID.
Okay, so piece of mail is.
Yep.
Yes.
Thank you so much.
Thank you, Mr. Dorsey.
Yes, thank you. I like to continue on this conversation. So a consequence of the dynamic that Ms. Crystal so artfully summarized is that people who were part of an employer group who did as advised and registered as a group and were therefore told you don't have to do anything, and who've waited their turn could in fact find themselves at a disadvantage if their employer group has not yet been called based on the priority allotment, but they themselves would be eligible, for example, as someone 18 to 64 with an underlying medical condition. So the consequence is that, and I'm not blaming us, it's the fault of the world, but that person could be disadvantaged compared to if they had just signed themselves up as an individual, as opposed to following the earlier guidance of waiting to be a part of an employee group. Is that fair to say?
I can see that. I'm not saying it couldn't have happened. We never said to people that they couldn't register in both capacities. So we know many people who signed up with their through their employer for their employee sort of activity, but no one actually said that they couldn't sign up based on age or in any of the other groups. So that was a universal sort of thing that people have done a lot of places. Whether people thought about that, I'm not sure, Mr. Dorsey, but I know people have done both. So I think some people, if they thought they could only register in one, that wasn't necessarily true, but it's not everyone in Arlington, for example, who lives here, works here. So they may have registered in our system, but registered in, say, Fairfax. And that's why some of the data that we're seeing when people go to the VDH website, I suspect we're the beneficiary of people working elsewhere, and that's why our number goes up. But you're absolutely right. If you chose to only do one, you could be, I can imagine why people would think that they were at a disadvantage.
Thank you.
Could I briefly interject to just say that our FAQ on the website does advise people that they can register twice in 2 categories. So not that everybody's following.
Yeah, if you've read
FAQ.
all of the FAQs, sure, I guess you can figure that out, but it's not necessarily intuitive for all. And we've had some communication from people who trusted that since they were on the employer list, there was nothing else that they needed to do. And, therefore feel like, wow, it's going to take me longer when I could have, been in line elsewhere. The next question concerns our messaging about Johnson & Johnson. So in the press release that we put out today, we use the word option, choice, but in fact, and I'm fully supportive of this, the way we're operationalizing this is when you are called for a vaccine, you get what we have available. You don't have the choice to determine which one you want, which I fully support. In terms of operationally, what will happen, to continue Mr. Karantonis' conversation, if they decline based on the availability of a certain type of vaccine, are we automatically going to roll them over to the end of the line, or will we just simply move past them and it will be up to them to pre-register again?
And thank you for the opportunity to maybe clarify a little bit of what I had said to Mr. Karantonis. As a general rule, when we get more of this vaccine in general, that is the direction we understand the state is going to. What they have asked us to do is, because of some of the concerns they've said, we're not forcing anyone. We're also actually inviting more people than there are slots. We never give actually the straight amount, because it could be that we then end up having people, for whatever reason, unable to fill the slots, and then we have vaccines sitting on the shelf. So we have traditionally, any of the weeks, invited well more than there are slots, and then tell people, keep looking for available slots in the next week and so on. So far it's worked. We'll see what happens. I've already gotten reports. We have over 400 people already signed up for it. So I'm hoping it will be a non-issue by the time it happens for Saturday. But this is unfortunately part of the angst that I've shared with our manager and Dr. Miller and the staff. This is what we're doing on a daily basis of saying, do we have enough invitations out there to make sure people are signing up? And people can, if they get our link eventually, if they've already been invited, they can sign up later. We have no way to stop that, in a sense. And if they were part of a group that was previously invited and they were slow to think about it, we're not stopping them in that sense. But as I said, we are generally, if in the example I gave, if they show up to the clinic for an appointment and then they say, I don't want Johnson & Johnson, I want Moderna, at that point, we're not going to put them back in the queue necessarily. If they can get to it themselves, however, I'm not asking questions, but that is the basic concept that I was trying to communicate. So I apologize if that was not clear.
Thank you. And just lastly, I know we're short on time. Can you put up the demographic slide that you put up earlier that shows vaccination rates with case rates and population rates?
Hang on.
I just didn't capture all of the detail, so.
So there are no rates on this. I just want to make sure that people are aware these are, the cases are and the vaccinations, these are the percentages compared to their population percentages. So, these two categories are presently on our dashboard for the race ethnicity data. This is the new information through the end of last week.
So, Mr. Dorsey, you may have a question about this.
No, go ahead. I just wanted to digest it. Thank you.
I actually think if you could leave that up, because I want to see if I'm getting the correct takeaways from what you said, Dr. Varghese. What I think we've all learned that data precision is a very difficult thing to get, but you can see trends. And I think what you said earlier is that, Dr. Varghese, is that, we think 26.4% of vaccinations we think have been Hispanic, which I think you indicated, and everything I've read is that our case, we've had cases have been even higher than that as a percentage, 40, 45%. But it is at least a good indication for me that, more than the percentage of our population, which is 15.8% Hispanic, has been vaccinated. Is that a fair takeaway?
Though I think we have to be very careful. Of the vaccinations we've done in Arlington County through the division, people are saying they've self-identified as 26.4% of that population. I would not say that the population of Arlington, it's 26.4%. Okay, so this is, I don't know if this trend will continue. And to the point that you made just before that, looking at the case data, the unknown category, earlier this year when we didn't get hit with, the 700 cases and we had to allocate our resources to just interviewing people rather than doing data entry to switch it, my gut instinct, like the last time, was this 30% number is likely almost exclusively going to move towards the Hispanic category. Sure. I'd like to be wrong, but this is why they talk about on equity, that right now inequities you can predict. The likelihood is when we do the unknowns and reallocate them once we can type that data in, is the Hispanic category will increase disproportionate to the percentage in the population. So that is why this is, so from an equity perspective, if we're really going to talk about it, it's not about their percentage in the population. If you're disproportionately affected by cases, then wouldn't it be great if we could actually vaccinate based on the disproportionality? And so if this were to be 30%, then why couldn't we first make sure that we focus on the Hispanic population in that way, if that helps?
Yeah, no,
Before we leave, Mr. Chair, if I could just ask a follow-up.
Sure. Go ahead.
So the case data differs from what appears on our dashboard with a significant undercount for.
No, this is actually from today's dashboard. Is my understanding that these are the cases by percentage. That the unknown percentage here, that's true today. We have not had the ability to type in the data from this category. We have it in a different system, and it hasn't been distributed among these other groups, most likely.
Okay, so I'm reading the dashboard and it shows similar amounts of unknowns, but Hispanic or Latino is substantially higher. What am I missing? I'm sure it's simple.
Well, I'm not sure which. I better go to the dashboard.
Yeah, I think you got a fair question for sure, Mr. Dorsey. I was just, for me, this seems consistent with my impression that we are being intentional. There is some evidence that the doses that we control, we're being intentional about trying to, and the free clinic is an indication of it, that we're trying to reach communities, our brown and black communities that have been harder hit. But I think it's a living example of how data is, hard.
Dr. Varghese, I think, sorry, Mr. Chair, to resolve this question, I think that vaccinations and cases might be transposed for Hispanics, if I'm understanding your chart construction.
And I did not check that, so I would be happy to look at it. But this is the dashboard I think you're referring to, Mr. Dorsey?
Correct.
Okay, and so this is the data so it is possible there was we got it at the very last second, so Let me just.
I mean, Dr. Borghese, your chart tonight would say that 26% of the Latino population, the people who received the vaccination and identify themselves as Latino were mostly distributed among the eligible groups of 75 and older, 64 to 75, and now also 16 to 64.
Could you repeat your question, Mr. Karantonis? Because I was looking at the data.
It's not a question. It's just an interpretation. Sure. that the apparently what appears on your table as a high percentage of people who received a vaccination and identify as Latino, that most of them have been distributed. They were eligible under the current groups of 75 and older.
Oh, 64.
Yes. So this is not necessarily a direct result of specifically targeting the Latino population. If this is true as it is, and I trust it is, that means that these recipients were among the eligible population in the cohorts that already have been eligible and have been vaccinated.
Yes, that is the interpretation.
The free clinic is just a recent addition to that, and I would hope that it would make such a big deal of a difference, and I hope it will at the end, right?
Sure.
I will check with staff, Mr. Dorsey. It could be that it was a transposition. I see what you were talking about. We literally got it about 15 minutes before this, so I don't want to compound any misconceptions if it is possible there was transposition. So my apologies.
Well, no worries. Yeah, I mean, my goodness. So I think we're getting close to wrapping up. I did one point, I think, is that if I heard you right, the free clinic work, it's not certain, but it's likely to start Saturday and
Correct.
Hasn't quite yet, but that's when it will if the logistics and everything can be worked out. Is that right?
So their intention is to do a first event on Saturday, and then after that, we're just saying how much that we can provide them, and then can they use it, and then we're leaving the details to them at that point, as long as they either use whatever they can and then return it to us so we can get it into arms. That's the current plan. We're not trying to be so granular because they've got to get it right. And then if the allocations increase, can we actually get them more resources or find more resources to use this mechanism as well? But we have to first make sure they can actually do it. So yes, you're correct.
Perfect. Great. So we're getting close. I think Mr. Karantonis, did you have a question? And then Ms. Garvey?
I had a simple question that's mostly Dr. Miller. So we have families, especially in more vulnerable and populations, minorities, etc., who just have one email address, and they go and after all they register, and so 3 or 4 different people will respond to one email address. So how is that handled by the system? And, how do they get distinct invitations? Because they are not all the same category or the same age or the same, eligibility.
Right. So to date, what we've been doing is we recognize that happens. We recognize that that's been happening. When folks ask us about that, what we've been saying is schedule in the order. As Dr. Varghese said, a lot of this relies on the good nature of our community, but we've been asking people to schedule that appointment for the individual in the order of the registration category. So for instance, if someone is 65 and older, schedule that appointment. The link that they receive to schedule that appointment will essentially be good for the remaining individuals that they need to schedule for. And so when the appropriate time comes, that they can go ahead and schedule for the other one. And then we do obviously have a process of taking the duplicates and double checking and verifying and identifying those where we see them, and then essentially assigning folks to quote case manage, figure out what that is, assess what's going on, and then go from there.
Okay, yeah, great. And I cannot stress, strongly enough how important it is to get this responsiveness of the system when somebody individual checks and want to see that their name is actually in there. That, especially for the employees of small businesses, etc. This is super critical because they cannot always really rely on their superiors in the business, etc. That they want to confirm, and that's a legitimate need.
Sure. Thank you, Mr. Karantonis. Ms. Garvey.
Yeah, thank you. I guess it's for Dr. Varghese, just to wrap up and finish up, actually. First, I think we are, again, I think it's the beginning of the end. And while we're not there on the equity issue, we have a lot of things to work out. Sorry. We have a lot of things to work out. We are getting there and we're honing in on it. And I'm really pleased at the work that you're doing and really appreciate it. So, Dr. Varghese, I feel I would be remiss if I didn't ask to go back to the first chart that you showed, the line graph, with the shaded area I always like to talk about. Because I noticed this time, as before, so we've got this, the graph shows this great plunge, but if I recollect correctly, hidden in the gray section is a pretty sharp increase. If you're able to pull that up. I
am, for some reason, having a hard time pulling that up. Let me just try this again. I'll talk about it if I can't actually pull it up. It's not a sharp. It's not a, well. It's all in your perspective. It goes from 255 to currently 307. So if you consider that a sharp increase, you consider it a sharp increase. The point is that it can actually, represent a delay in testing. So you're absolutely right. It is possible that number could go back up, and so that it went down and maybe is on the rise again. 2 data points doesn't necessarily mean a trend, but it is always worrisome, and it's why we're reminding individuals to continue with the other layers of activity, because we do need people to take this seriously, because we still have the virus present, and I am trying to figure out why
that was my PSA to while we end up. In fact, I think there was just a discussion today that I don't know if it's the head of the CDC or what, saying that, we're in danger of getting a fourth surge. We need to really double down on the masking and being careful. And that was my point. You can sort of see that in the graph. There's this plunge, but don't, see that it's starting to maybe tick up again. And everybody just needs to continue to be careful no matter. So that was my point, just to conclude. Thank you very much. Thank you, Mr. Chair.
Thank you, Ms. Garvey. So we have, on that note, we'll wrap up. We have reasons for cautious optimism, 1,500 new doses. We're on to 16 to 64, and we're getting out 88, 89, 90% of our doses. We are working flat out. If you don't have yet your vaccine, that may not be much solace to you, but there are many people who are waiting, as are we, and we are working hard to try to serve you. Take care of yourself, stay safe, mask, distance. Let's get through this last beginning of the end of this pandemic together. Thanks very much. Good night, everybody.
Yeah, good night. Everybody stay well. Thank you so much, everybody.
Good night. We're adjourned.